chance to look at the minutes from the previous meeting?
I make a motion to approve.
Second.
Stand as, with no corrections, they stand as posted. So today we're going to have a presentation by Pat Freilich and Pat Fontana.
Thank you. Good afternoon. It's nice to see everybody.
It's
Been a long time.
It has been long.
No, some of us aren't necessarily physical. We're better off not.
Well, that's all on you guys. I'm happy to see you all. So today is an opportunity. I'm going to really turn this over to Pat Fontana. But many of you are aware that we are in a year 2 of a study in regards to opiate overdose and opioid abuse. So believe it or not, it's been over a year. We're now in the first quarter of year 2. And it's an opportunity for us to bring you guys up to speed as to what, where we are, where we're going with this. Pat Fontana is the Director of Population Health for Fort Drum Regional Health Planning. We've contracted with them since the beginning to provide oversight for the project. They bring with them a lot of expertise and experience in regards to gathering data, convening people together. It's really kind of the foundation of what they do. It's been working out very, very well. So Pat Fontana, I'm going to turn this over to you to talk about our study.
All right, thank you, Pat. Thanks very much. I appreciate very much, and thank you so much for giving me the opportunity to present this to you. I usually say that half-heartedly, but the fact that I was able to get out of the house, get in my truck, and drive somewhere, I really do appreciate the opportunity to be here with you today. So as Pat said, the Communities That Heal, or the Healing Communities study, has been something that's been going on for quite a while. And I'm not sure if you're familiar with NIDA, but NIDA is the National Institute of Drug Abuse, and they're a federal research agency under the U.S. Department of Health and Human Services. And they're conducting the largest study of its kind, according to them, in studying the implementation process of EBIs, which is evidence-based interventions that are targeted at reducing the opioid overdose deaths. And so I'll say that one more time because we had to hear it about half a dozen times until we figured out exactly what that meant. They're not studying the evidence-based interventions to address the opioid epidemic. They're actually studying the process by which those evidence-based interventions are implemented. Because if something's evidence-based, it already went through that vetting process and it's evidence-based. It's already a proven intervention of sorts. So they essentially have given us a playbook, NIDA has. And in this playbook is a series of evidence-based interventions or practices or things to do to help with the opioid epidemic that they know work because there's evidence that shows it. And basically a playbook on when to use it, how to use it, what resources to use, what not to do, when to do something, when not to do something. So that's essentially the playbook. And they're studying not only that playbook and see how effective it is, but they're also studying the process by which each individual county in certain areas implement that, and then kind of see if it's a rural county, what did they do, was it effective compared to this rural county, and things like that. So the goal that they gave us was to reduce opioid overdose deaths by 40% by the end of this study. NIDA has contracted or collaborated with 4 states: Massachusetts, Kentucky, Ohio, and New York. Why? I don't. It's probably based on some type of need, probably based on some federal data. I'm not sure, but they partnered with these 4 states to do this study. And in New York, Columbia University was the entity chosen to enact this study or implement this study on behalf of NIDA, if that makes sense. There are 2 waves, or two wave counties, if you want to call them that. There's wave 1 counties in New York State, and there are 8 of them. And there are wave 2 counties in New York State, and there are 8 of those as well. The wave 1 counties are the counties that you would consider, if it was a randomized control type of study, we would be the study group. We're the group that they're showing us the playbook, they're giving us the interventions, they're helping us out the best they can, and they're studying what we do. We're that study group, so we're wave 1. Wave 2 counties are being studied as well, but they're not getting any help at the moment. So they're doing whatever they're doing. And so they're studying their process. And that's how they're going to compare the two afterwards. Wave 2 counties eventually will be given the playbook to see if things change along the way. So that's kind of how they set up this study process. I've never seen anything like this before, to be quite honest with you. So it was interesting to be part of it. It's also frustrating to be part of it sometimes, but it's very interesting. And they do come with a lot of background and a lot of good knowledge. So if there's any questions at all, please interrupt me at any time. Just to give you a quick picture of the counties that were chosen. And again, the counties that were chosen were based on a lot of different demographics and needs and different data, but Lewis County was one of them. We're in wave 1. We're considered obviously a rural county. You can see the orange checkered at the top. We're kind of there by ourselves way up there at the top. And you've got some other rural counties in New York State that are being studied too in wave 1. So we're one of the 4. Does anyone have any questions so far as to how they set this up? So what are the evidence-based interventions that they want us to implement? They're broken up really into 3 categories. You see Lewis County, then you see a steering committee. And what they wanted was, they wanted a steering committee formed. They wanted a group formed of stakeholders, people that had a stake in addressing the opioid problem. People that are in the healthcare industries, community-based organizations, persons with lived experience, and so on. And that steering committee was tasked with implementing 3 evidence-based interventions. One of them is what they call OEND. And OEND is opioid overdose prevention education and naloxone distribution. Naloxone, if you're not familiar with naloxone is it's a drug. It's called an antagonist that, if taken, it reduces or completely eliminates the opioid effect. It blocks the transmitters, or whatever you want to call it. I'm not a doctor, obviously, you can tell. But it blocks any of that euphoric feeling that you get from opioids, and it will revive somebody if they're going through an overdose. Yeah.
Is that a liquid or a spray or what?
It's in a couple of different forms, but the most common one is the spray. You spray it right up in their nose. Yes.
Is that Narcan?
It is Narcan. Yes. 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 Thanks. Yes, it is Narcan. That's the generic. So that's OEND. So the one they said is try to advance naloxone education and distribution in populations that are high risk. Basically, for lack of a better phrase, stop the bleeding. Just keep people alive until you can get them the proper help that they need. The next one is, they call it MOOD, M-O-U-D. Some of you might be familiar with the term MAT, or medication-assisted treatment. They call it medication for opioid use disorder. And essentially what that is, it's like diabetes medication. Some people take diabetes medication, take a shot every week or something like that. This is very similar to that, where if you do have an opioid use disorder, what this particular type of medication, like buprenorphine, Suboxone, you might have heard Suboxone before, that type of medication isn't an antagonist where it blocks the effects of the euphoric effect of opioids. What that does is it's a partial agonist, where it's an opioid in and of itself, but there's a cap on the euphoric feeling. So it kind of maintains that individual at a level where they won't have these cravings where they will go off on the streets and use. The hope is, for most, is that you will taper them off eventually and they won't need to have anything. That's the hope. And then there's safer prescribing. And the safer prescribing, to be quite honest, I think that's going to be the easiest thing to implement, not only because it's partially being done, but because we've got people that know exactly what's happening and exactly where to target on the, as far as the providers are concerned. So that one's that's the one they want us to focus on the least, but I think that's going to be the one that we end up being able to do the greatest amount in, is to make sure that opioids aren't being given if they don't have to be given. If somebody comes into the hospital with a acute, pain in their back, or they have a chronic pain of some kind, to try to find some alternative means other than opioids so somebody doesn't become addicted afterwards. So those are the interventions that we're working on right now. And so The steering committee really feeds and drives the initiatives for all of these evidence-based interventions, but that steering committee also has broken up into 3 work groups. It's actually 5, but 3 work groups that are designated to work on each individual intervention. So we have a work group for naloxone, OEND. We have a work group for MOUD, and we have a work group for safer prescribing as well. And we also have 2 other work groups. We have a lot of work groups, a lot of meetings. But all of these work groups feed the information to the steering committee. Most of the work groups are part of the steering committee, to be quite honest with you. But we have a communication, so you'll see campaigns on where to find naloxone, you'll see campaigns on where to get treatment and things like that. Anti-stigma campaigns for communication. Surveillance data, we're trying to figure out what's the best way to bring data to the stakeholders. So we have a data surveillance team, and then we have the 3 evidence-based intervention teams as well. And so really, what we've done so far has been to identify the existing services and resources that are already here. And there are quite a few. For a small county, you have a very robust set of services and resources that can be leveraged. And then we performed a landscape analysis. Columbia actually did most of this, where they went and they figured out what are the existing services, what does the community look like as a whole, the demographics and things like that. We looked for available data and sources of information to help drive our decisions. We identified any gaps that existed. To be quite honest, most of the gaps, it's interesting, it's not quite like we've seen before, like the Jefferson County, for example. But the gaps are more or less, it's not a provider to patient ratio. You know what I mean? Like you have 1 provider to 100 patients, let's say. That might be the same from Lewis County to other places. But you'll find in Lewis County and places like St. Lawrence County that it's not so much the ratio of provider to patient, it's the inability sometimes of a patient to be able to make it to a provider because they don't have proper transportation. Or the provider isn't 3 blocks away, the provider is 30 miles away instead. And that causes some barriers too. Or self-service isn't quite good if you want to do a telemedicine encounter. So really the gaps we're finding are those unique gaps to rural areas. That's been a lot of our frustration with Columbia, because you're talking about a big university and a very big city that have a hard time wrapping their head around a county with 26,000 people in it. So when we tell them we have 1.5 providers for this particular thing, they're usually looking at something like 2,000 providers in a county, or or whatever it is. So we're teaching them and they're teaching us. That's kind of the way that it's working. And I guess if you're in a study, that's kind of the way that it should be. But right now we're developing an action plan with many of the partners in Lewis County to come up with evidence-based interventions that make sense for the county. Evidence-based interventions that are already kind of underway. So we're trying to take what's already there and enhance it for our partners that are here. And we're trying to utilize, we have impact, we call it impact dollars. But there is money to kind of implement some of these evidence-based interventions in certain areas as well. So we're trying to figure out, along with the Lewis County stakeholders, the steering committee, what's the best approach to implementing these evidence-based interventions. And at the same time, we're trying to walk that tightrope and follow what Columbia says we have to follow. But we're always erring on the side of, let's just do what's best for the county and apologize to Columbia afterwards. Because what generally happens is somebody comes in, they do a study, and then they leave. And then whatever's left, the people of that community have to deal with. So we understand that. We're part of the community, and we want to make sure that what's done was a decision that was made by the community. It's something that the community can, they think there's a feasibility that it can be done and that the impact is going to be pretty good. So that's where we are trying to focus on. Sometimes that has a little bit of a corner, but that's fine. Just to be quick, I know it's time to quit here, but this is essential. This is an overview of one strategy within one of the evidence-based interventions. And there are pages on this, but I'm just giving you a quick example of what we're looking at. For example, we're asked to implement naloxone for at-risk individuals in their social networks. So choose one of the following. Try to enhance naloxone services or education in these areas: criminal justice, syringe service programs, emergency departments, acute hospitals, leave behind program at overdose sites, and things like that. Choose one high-risk population and then choose a sector to implement it in. So that's essentially what we're doing. There are some required tasks and some optional tasks, and we're trying to pick what's best for the county. And usually it ends up being what the county is trying to do already or what has done already. How can we just enhance that? There is a data portal. I could show it to you, but you're looking at the entirety of the data portal right now in this snapshot. That's what the data portal is. Columbia's putting together a data portal for us. Right now it goes up to it says 2019, but most of the data is up to 2018. I'll tell you what I don't like about FERC is that it requires a username and password, and I would like it to be a community-facing portal. I think we can get it to be. It's not our decision, but I think we have a lot of influence as to how this is going to be used later on. So this portal will show somewhat of a real-time, eventually, a real-time set of data on what is going on with opioid overdose deaths, with administration of naloxone, with naloxone kits distributed, and so on. That's going to be a tough thing to do, but I think it is very doable. The pieces are in place. They're just not connected together yet, and that's what we're trying to do at this point. So we're trying to help Columbia with that data. To be quite honest, because of COVID, not that that's an excuse for everything, but because of COVID, Columbia has had a very tough time getting any data from them, and that's where a lot of this data has to come from. But some of it comes from local departments too. So we are working on this. This is something that will be evolving in the next 3 years, and I'd be happy to come and present it to you when it's in its full form. They really just put those four there to show people that it's going to be a good portal at some point in time, so there's something there to look at. But that's essentially it. There are other documents on there for the steering committee on that same portal as well. And I think that's why they limit it to just certain users.
So, if I'm reading that correctly, we're sending on average between 25 and 35 people a quarter to OASIS
Certified Treatment Program. No. Okay, so I recall reading that one a while back, and that's deceiving. So, yes, that's
we pay the bills at DSS.
yes,
We don't pay
that's deceiving. I believe that is the number of admissions to OASIS Certified Treatment Program. I think that's the number of admissions, not the number of people.
Okay.
So one person could be there 10 times.
Yes.
One person could be there 15 times. And so that's another thing that Megan and I, you notice how it's purple? Because Megan and I, we clicked on it and I said, wait a minute, that's too deceiving. They've got to change that. And not have it just so you have to click on there to figure out what that means. So again, there's certain things and we're trying to help them with that. These are good data people, but when it comes to this type of data, they need to be assisted with like an epidemiologist who knows about diseases and things like that a little bit. Because they'll put the data down very well. What they have a hard time doing is getting it so it's interpreted, so it can be interpreted correctly. Yeah. So that's the data portal. And then, again, I'd be happy to, and I think you have a packet there. We do have 3 websites. These aren't ours, they're Columbia's, and they will be ours. But the community-facing website is available to everyone. It gives a brief description of what the study is about. It gives a brief overview of where naloxone can be found in the community and where people can receive help. And that's essentially it right now. That is a work in progress as well. It will have a community profile attached to that eventually too. Website 2 has a series of campaign materials that a professional campaign company put together that is targeted just for Lewis County. So other counties can't use it because it has Lewis County all over it. So it's again a campaign materials to where to get help, what to look for, what signs to look for opioid overdose and things like that. And then there's a third website, which is the data dashboard that they're working on. So I would say all of these are a work in progress. They implemented them, they have them up and running, but they're not at their full potential because it's a 3.5-year process by the time it gets completely done. And that's essentially, I only had 10 minutes, I probably took 20, so I apologize, but I wanted to make sure you had at least somewhat of a comprehensive overview of what we are trying to do. And bottom line is, and we talk about this all the time, you've got kind of I'm not even going to say, well, not opposing goals. You've got goals that are generally the same, but how to get there, sometimes there's a conflict. We're always going to err on the side of what's best for the community, not what's best for the study team. It's just that's our main focus. That's always been our focus, and I just wanted you to know that. And that's one of the reasons I'm appreciative of you giving me the opportunity. That, and I was able to actually get out of the house today and go for it. But if you have any questions, feel free to contact me or Megan Donato anytime.
Excuse me, with the MOUD and the prescriptions,
Yeah.
does somebody have to go to mental health to get a prescription for that, or can a doctor do the prescription, or how does that work?
Well, both. So doctors, let's say a primary care provider. Now a primary care provider can become trained, get a waiver to prescribe that type of medication. So if they opted to get trained, then they'll get the training, they'll apply for certification, they'll get that certification, and that certification allows them to prescribe that medication to their patient.
So would it be fair to say that currently that's not a good option? That's not a readily available option, I guess is what I'm trying to say.
Here?
Yes.
That's a tough one to answer because you've got very few people let's say provider A has 2,000 patients. One patient is going to have an issue. That's what we're finding, one patient. And for that one patient, the amount of work and resources and time that goes into being able to do this. It's not just getting waiver trained and being able to prescribe. There's many other things that go with it, apparently, that the doctor, a lot of times the practices, it's not, don't want to say not worth it, but it's almost not feasible to do. Especially when you have a practice down the street whose sole job is to take care of those things. So for certain places it would make sense. For other places, it doesn't make sense, and that's what we're trying to determine right now. If you're in a big city and you have a substance use doctor that is at capacity for this medication, and they can't fit any more patients in, but then there's 4,000 patients that need help, then you want to get as many primary care doctors on board to take care of that. In a place like here, it might be just a matter of a primary care doctor and a substance use agency having maybe more enhanced communication so they can make sure that things are being done at the SUD place, at the substance use place.
So where do they go? Do they go to mental health?
They go to Credo.
They'll go to Credo.
They would go to
Okay.
Credo.
That would be your substance use
Yeah.
agency here, yeah. Yeah.
All right.
So a primary care doctor will generally refer them to Credo, and then that communication process gets started.
But they have to ask for it. They have to ask for the help.
No, not necessarily. A provider can refer. The patient can choose not to go, but a doctor can refer and make that referral. And correct me if I'm wrong.
No, you're
Most of our referrals probably don't come through a primary care. They probably come through Jenny's office.
Do what?
Jenny's office. Because if they're trying to get their benefits, that's when they run up against the tension with their substance abuse issues. That's when they get referred to. So they're probably not dealing with medical folks until
Or
they,
child welfare.
yeah.
And I think the other is the legal system.
And
There's
the
another
whole legal system.
referral.
Well, we've talked to several primary care providers, and we really thought that this was the place to enhance services. And the more we talk to them, they're willing to talk and try to figure out ways to do it. The more we're just internally, we're thinking maybe there's a different way to do this, because if we have to upend so much for one or two patients, that it would be doing the patients a disservice. But if we can have that communication, if we can try to figure out a way, usually it's a regulation issue with communications, HIPAA, CFR 42 type of stuff, where one can't say one thing to the other, and that we're trying to facilitate the communication the best we can so they can communicate the best they can under these regulations that are in place.
And I think the challenge when you have someone that you're treating for a substance use disorder is that sometimes more isn't always better. Because if you have 5 choices and each 5 providers are doing it a little differently, it doesn't provide continuity to the patient. And it is a whole different population in your medical practice. It's a different process, it's a different purpose, and it's just hard to acclimate. It's very hard on the staff and whatnot. So in actuality, by having a few providers providing it consistently, making sure the referral sources can get people where they need to be timely, it actually would be a better system.
So thank you.
Yeah.
It's a complicated, way to try to figure it out. But that's all I had. Any other questions on the process of the study? Be happy to give you updates as we move along on this. It'll be an interesting process, I think.
And I think the other thing that while Patrick and I are up here talking about this has been a county department commitment. So a commitment on Ryan's piece, both Jenny and my mind just went blank. Ashley, good God. Looking right at her. And Ashley has been a significant part of this because they have their expertise and their direction. And there's a lot of community members that are also not on the steering committee but are helping us out with the small groups.
Well, thank you very much. Appreciate it.
Thank you.
I forgot about next too. Next banana.
It'll be 9 minutes less next time.
The first one is resolution authorizing a modification and extension to the agreement between the County of Lewis by and through the Lewis County Office for the Aging with Open Sky Wellness to provide professional nutrition consultant services on behalf of the Lewis County Office for the Aging's nutrition program, commencing with the fee of $38.76 per hour on September 1st, 2020, then $40 per hour on January 1st, 2021, and $44 per hour on January 1st, 2022, for up to 16 hours per week for such services.
Any discussion or questions? All in favor, say aye. Opposed? Carried.
Resolution authorizing an agreement between the County of Lewis by and through the Lewis County Public Health Agency and Bernie Bus Service to provide transportation services for preschool special education children.
Randy, if I could address that. Ashley and I have been trying for, I would say, 3 or 4 weeks now to try to solidify the terms of an agreement with Bernie Bus. They were the one bidders. We did go out to RFP. They were the one bidders. Their proposed fees for this service are, this is like $30,000 greater than last year's, maybe a 17 or 20% increase. And so we're not quite there yet. Of course, if need be, we can go into executive sessions a little bit later to let you know some of the terms that we've been discussing. But we're not quite there. Ashley needs to have this in place by July because there is a possible student who may have to be transported. So we're talking about maybe even working out some kind of interim temporary thing for July and August if we can't work out the terms for a year's agreement or so. So I'm going to request that maybe after we go through all the others, we just have a quick session to bring me up to speed.
Okay. All right, thank you. Anybody have any questions or discussion further on that? All in favor?
Am I the only one?
No, I'm looking at the other one.
Everybody's sleeping.
Based on what Norma said,
what are we
Are we
doing?
gonna, are we supposed to pull this one? for
Yeah, just table it for now.
Table it for now? Okay.
Yeah, I'll make a motion to table.
Okay. All in favor of tabling it? Aye.
Aye.
Who seconded that motion?
I did.
Resolution for a budget transfer in the amount of $3,000 to the Department of Social Services accounts for the purchase of various computer equipment with funding to come from Project HAE Capital Equipment.
So this is the fund, now that we're doing virtual court, we have to set up our child support staff and all of our staff that appear in court cases with virtual cameras and other equipment so that they can Skype in more or less to court. So this will be covered 75% by the state and federal matches, but is there anything else involved with this, Jenny?
We're reimbursing us out of the capital plan. We had to upgrade the server for DocuWare,
Right.
so there's like bits and pieces of about 3 or 4 different things. We needed external DVD drivers for some of our laptops because that's where our medical records come in. So it's kind of little pieces of lots of little equipment needs. We don't have our own computer equipment line, so we have to do a resolution because we don't have the line in our budget.
Any more questions or discussion? All in favor, say aye.
Aye.
Opposed? Carried.
Resolution authorizing agreements between Lewis County Department of Social Services and various foster care agencies for the provision of foster care services, emergency respite care, post-placement, and residential, educational, and treatment services with a term commencing January 1st, 2021 through December 31st, 2021 at a per diem cost not to exceed the maximum state aid rate established by the New York State Department of Health.
Just a comment, it's just a typo, it should be Office of Children and Family Services, not Department of Health.
Any discussion or questions on that? All in favor, say aye.
Aye.
Opposed? Carried.
Resolution appointing student representatives to serve on the Lewis County Youth Bureau Advisory Board for a term effective July 8th, 2020 through to the date of their high school graduation or upon ceasing to be a full-time high school student.
Any questions or discussion? All in favor, say aye.
Aye.
Opposed? Carried. And before we move to executive session, do we have any questions for any of the department heads that are in the audience? Do you guys have anything to offer?
I would tell you we're distributing another pandemic SNAP benefit. It'll be out over the course of the next 10 days. So that's, again, bringing everybody to the household maximum for SNAP benefits. This is the 3rd month in a row. Also, the May-June pandemic benefit for students that receive free and reduced lunch that are on SNAP will be done within the next week as well. So all in all, we're up to about $1 million additional SNAP dollars into Lewis County in the last 3 months. About almost $1 million more dollars. Yes. So there's lots of, it trickles in month to month, but we got the notice today that we can get it out.
Thank you, Jenny. Okay. So I need a
Motion to move to a brief executive session.
Randy, real quick, I'm sorry, I should have spoke up before. I did ask Ashley to pop in today since we are still under state of emergency. We are still in a pandemic. If there was anything the legislators wanted to ask with Ashley, I should have touched base with you before, but
That's fine. Nobody said anything.
Can you give us a little update, Ashley, on how phase 3 with the restaurants and stuff is going and how it's being monitored?
Well, it's being monitored by the public. We haven't received any phone calls at our office with complaints. I feel like it's going well based on that. We've received complaints right up until for various other things. So I think it's going well today.
We haven't received any complaints through the state report system either since phase 3 started, at least not for restaurants. We do get, Walmart has been pretty consistent about people wearing masks. Here and there we get one or two, but for the most part, I mean, I've heard from other people, their complaints are dozens a day. Ours are probably one a day, if that.
So if you do get complaints, do you have to go out and see for yourself, or you just document that?
We do call and make sure that they know of the guidance, they have the proper education. That's our role, is to educate and make sure they know of the safety precautions that should be in place. And if further complaints come in, then that would go to the sheriff's office.
Thanks.
And then Joan follows up with a letter.
Any of the complaints we get through New York Falls, I follow up with a letter to the entity, just reminding them to abide by the guidelines.
So none of those 25,000 complaints came from Lewis County then?
Maybe 8 of them.
Just going by what I hear. All right, anything else for Ashley? Can we move to executive session? Need a motion to move to executive session?
Yep.
Phil, second? I'll second it. Greg seconded. Guess we're going to executive session for a brief amount of time.
Very short. Stay.
This is too much for me.
Matter of fact,
Really sleep.
Moved a little quicker when we were on Skype.
Yeah, I think we did.
Transportation Attorney Bus. Any more discussion on